Good morning, everyone, and it's nice to be here in the morning at 10 a.m. The hall is much more fuller than what I thought it would be, and hopefully, and a 40-minute panel is also nice, but I will like to finish in 35 minutes because I have a flight at 1 o'clock, would like to leave early. Okay, second line therapy for metastatic non-small cell lung cancer should not have been the plan A, but this became the plan B, became plan A because I requested to change from Dr. Sahu because I had a flight. So, my disclosures and conflicts of interest about this particular thing is, I think I am a medical oncologist or everybody else is a medical oncologist who knows that, treating cancer is like a marathon, it's not a sprint. We understand that. And life is exactly about how you handle the plan B. Everybody will have plan A, but plan B is something which is very, very important. And move over Rohit Sharma and Kohli and Ashwin, we now have the plan B in Indian cricket team. I took only yesterday because I wanted to see how much they score at Lords. If they had not scored well at Lords, I would have put something else actually. So, we have two different cases. One is an oncogene addicted non-small cell lung cancer, one is a non-oncogene addicted lung cancer. We will start with the first one. It's a 55-year-old male, non-smoker, who is a stage 4 non-small cell lung cancer, diagnosed as adenocarcinoma in 2022. The site of mets basically are right lung with contralateral lung nodules, mediastinal, supraclav lymph nodes with bone metastasis. MRI brain we do for everybody which has not shown any evidence of brain mets. And just a point over here, from the last 5 years, we have incorporated, I think Dipen is there, he will understand, he will tell you, when we do PET and MRI brain, we have a package at our hospital and they actually do MRI almost complementary. So, a PET scan costs around 19,000 rupees and a PET plus MRI brain actually costs around 23,000 rupees. So, we do MRI brain for everyone. And our incidence of brain metastasis in a EGFR mutant non-small cell lung cancer, symptomatic or asymptomatic diagnosis is 48%. In ALK, it is around 50%. So, even if a patient is asymptomatic, if we do MRI brain, I think it makes sense to do because a lot of treatment management will change and the incidence is as high as 50%. So, I think we should definitely do. We do PET CT scans over a series chest and abdomen for a 6%, 7% benefit. There is a benefit of around at least 20% in this. So, I think we should definitely do. This patient NGS was sent, which basically came as Del 19 EGFR mutant, P53 also was mutant. It was 2022. So, we started the patient on osimertinib, the FLORA protocol. There was no FLORA 2, there was no Mariposa, so I am not getting into the nitty-gritties of that. So, again look at this, the patient has a right lung mass, contralateral lung nodules, mediastinal, supraclavicular lymphadenopathy and bone metastasis. So, this is the site of metastasis, no liver is there, nothing is there. Patient obviously gave osimertinib, responded to treatment, nothing great. Initial evaluation after 3 months showed some response to treatment. The PET scan report normally come as sometimes good partial response and there was some response to treatment. The metabolic activity actually became 20% lesser than that, the size also reduced. This patient was continued on osimertinib. In July, he had a sustained response to the original sites, but there was a new lymph node over here in the posterior cervical lymph node. Now, they actually told us supraclavicular lymph node, but when we discussed the case in tumor board, it was the posterior cervical lymph node. MRI brain was done right now also, the patient was absolutely all right, ECOG PS1. So, this is what I will show you here. Left lung lesion shows mild decrease, infiltrates are unchanged, pleural effusion has regressed. Posterior cervical lymph node shows mild increase in size and activity. Rest of the lymph nodes are present, bony lesion show decrease in activity. So, that is it, just some posterior size has basically increased. This is what the initial PET scan was. This is what the reval had shown. There was a slightly good response, the effusion has more or less come down. And this is the lymph node as we can see over here, which has basically come up, which is definitely, this case was discussed in tumor board. And this was, the nuclear medicine people said it was very, very suspicious. So, I will start from this side since you came late, Pinaki. What would you do?
I would biopsy if it is accessible.
You will, it is a posterior cervical lymph node, it is accessible. And if it is positive, what will you do?
So, if the patient is on a long drawn treatment, which is,
it's 8 months. It was started in November, see we have 40 minutes today and they are not going to cut off the time. So, we have enough time. So this is, I will show you the things, and this is a real case. I will show you what exactly I did. Everything I did was wrong in this patient, but I just want to hear from everybody else.
So I would do a biopsy. If you are saying it's 8 months, then I would try to repeat an NGS, see if I've missed something in the initial report.
Biopsy,
Continue.
NGS. NGS shows something actionable. Let's say a MET amplification. So with this mild increase in activity, rest everything is stable. There is no right answer. Yes. So you will biopsy, you will send an NGS, and you will change the treatment.
I would try to change the treatment if I get something out of it.
Fantastic.
So it is not a new lymph node, just an increase in size of the existing lymph node. That is what I understood.
So there were a lot of supraclavicular lymph nodes. This lymph node has shown increase in size and activity. They said, sir, it was there before, but it was less than that. Now it has increased in activity. It is still a small lymph node.
I will still closely observe it, and I will continue with osimertinib.
Continue with osimertinib. Yeah. If it was today, a new thing would have come up, we'll add chemotherapy to it. But FLAURA2 was not there at that time, and today we will do that. Okay, yes, Bhuvan.
Yes, sir. I agree with my earlier panelists. There's
no, there are two colleagues. One is changing treatment, one is not changing treatment. You can't agree with both of them.
Immediate one. I would like to observe, considering the same lymph node which is showing mild increase in activity, rest of the lesions are stable. So I would like to observe.
Continue osimertinib, and उसके बाद देखते हैं क्या करना है.
Sir, I would like to observe.
Fantastic.
Continue osimertinib.
There's a radiation oncology symposium which is happening over there, just to give some ideas over there.
Since it's a oligoprogression, I will like to continue with the osimertinib.
Oligoprogression, you will like to continue with osimertinib.
Yes, sir, I will also continue the osimertinib.
Fantastic. So there is a concept in oligoprogression. So there are two things. One is treatment beyond progression. One is oligoprogression. Oligoprogression, nobody wants to give radiotherapy over there. The radiation oncology colleague says that, okay, fine, we will biopsy. If it is positive, we'll give RT to this, and you continue osimertinib. Anything wrong in that statement or right in that statement? It's an MDD. I mean, what happens in the MDD, you have your radiation people next to you, and forget the radiation. The surgeon said we will do a biopsy, take it out. The IR people said we'll do RFA of this. It is very difficult to counteract that. So yes, anybody has this is what I exactly thought. We had 5 different options. Continue osimertinib, just a radiological progression. Somebody will say we have to treat a patient, not a report. बाद में देखते हैं क्या होता है 2-3 महीने बाद. Second, as you said, biopsy the upper deep cervical lymph node. कुछ भी हो सकता है कि tuberculosis हो जाए, send for a gene expert. Third is biopsy and send for NGS and change the systemic treatment. We are a precision medical oncologist. We don't want to, if this throws up more resistance over there, anything can happen over there. RT to the oligoprogressive site, MDT discussions. So the radiation oncologists, when I told them this, they said कि अगर आपको osimertinib भी continue करनी थी, तो फिर लेके क्यों आए हो यहाँ पे? And I said, okay, fine, that is also right. For a oligoprogressive site, that is also okay. You will say change systemic treatment. It's time to, get chemo before it's too late. Anybody from the house, Amol, what would you do? Let us say you go to a new hospital which has radiation oncology and surgery and everything over there. Biopsy will show, no, it is 40 minutes is there, biopsy has to show, it's a plan B. Okay, NGS shows something drastic. Anybody else? It's okay, we have all come in the morning to listen to this only, no? Okay, or just get some entertainment.
This patient actually also had a P53, sir. So,
yes, sir.
So we know that historically those patients probably don't do well on monotherapy, probably. Now we know,
Okay, so ideally there is no right answer. Sab theek hai. Yes, please. Correct. So this was 2022. In fact, a new good option right now would have been, which I'll come to it later, is to continue osimertinib and add chemotherapy, the FLAURA2. Is it a typical FLAURA2 regimen? No. What is the benefit of continuing osimertinib? I'm going to come to it. So, by and large, the last statement over here is the right one. Sab theek hai. There is no right answer, there is no wrong answer in this, everything is all right. And I think I would probably agree. I am one medical oncologist who is a very ardent believer of oligoprogression, oligopersister, oligo-residual disease, and we do give RT a lot, and our RFAs and all in our this thing, with a very very nice clear statement in your mind that we are only going to delay progression, increase the PFS slightly, and may not really have a change in the overall treatment. So there are three types of progressive disease that we have. We have a systemic progressive disease, we have a oligoprogressive disease, and you can have a CNS progressive disease. In a CNS progressive disease, you basically irradiate the brain, continue with the particular treatment. In the oligo-PD is where the doubts are basically coming on over here. Systemic PD, we will come to it later. And in a systemic, here it is there. This is what my radiation oncologist showed. If you have a systemic PD, again, this is for symptomatic. This patient was not symptomatic for this. The attendants were symptomatic for this, but that's okay. We will see what it goes. Everything is right. So first tip over here is not all progressions are created equal. I think we need to address over here which is the oligo progression versus systemic progression, and then talk to the people over there. So this patient actually underwent biopsy of the posterior cervical lymph node. Biopsy came as adenocarcinoma. This was discussed and hotly contested in the multi-specialty meeting, and in fact I would stick my hand up and said, I was the one who said कि नहीं एक ही जगह पे है. The only idea over here was to continue osimertinib, because otherwise I said, we may have to add something onto it. Since osimertinib is there, patient is, I think they were getting it free or something. So I said, okay, fine, let's just continue with that. We gave RT to the oligoprogressive site. Now after you give radiotherapy to the oligoprogressive site, I'll start from this side. Will you continue osimertinib? And what will you tell the patient at this particular time? What is the advantage that you are expecting out of continuing osimertinib?
Yes, continue the osimertinib.
That was the entire point of doing this thing. Yes.
Yes.
What will you tell the patient? I mean, normally when we say the median PFS is around 18.6 months. This was 8 to 9 months right now here. What is the expectation that for how long will the osimertinib actually, or radiation will actually continue, will give it benefit?
So we have to continue the osimertinib till when the multiple lesions, disease has been progressed in multiple lesions.
Systemic progression.
Systemic progressions.
What do you think is the approximate benefit which you may get from adding this oligoprogressive treatment? Are we talking in years? Are we talking in months? Are we talking in weeks? Nobody has an idea. So this is a data free zone. Nobody knows anything. So anything.
Few months.
Few months. Fantastic. So actually the radiotherapy, and this is what when they came and I'll tell you this, they came and told me about radiotherapy oligoprogressive. Then next tumor board I came and told them this data over there. So oligoprogressive site and some local modality treatment has been tried. It's not that it has not been tried. Retrospective studies, by and large what you are talking is a median PFS of around 4 to 6 months. That is all that you are talking about. So they will say that so the only reason, and again I will say why we gave radiotherapy and continue and this thing was because else patient would have to go to chemotherapy, else patient may have to go to something more expensive, and the patient was doing with an osimertinib. So but I knew and I told the patient that it is not going to be more than 4 to 5 months that we are expecting a progressive disease. That is the most important thing. The expected PFS2 is only around 4 to 5 months. That is there. This was another trial basically, for continuation of, sometimes what also happens is, I also spoke about treatment beyond progression. Let's say a PET scan basically comes and they show the slight increase is there, patient is absolutely asymptomatic, and we continue. Again, the PFS that you expect, the PFS2 that you expect is not more than 2 to 4 months. I mean, that is very, very there. There is a modest improvement with the use of local ablative therapies, treatment beyond progression, but that is not great. I mean, that's not 9 months, 10 months, 1 year. That is something which we should be absolutely clear about telling. So, patient was continued on osimertinib. After 4 months, as expected, patient had systemic progression with increase in skeletal numbers. Now, this is important. So, this is an MSc. You have Gagan Saini, whom I met at breakfast, who has joined recently at a new radiation center with protons and everything. He said, boss, हमने यहाँ radiation दिया था. This was anyway getting controlled. Now you have 3 new numbers and 1 new adrenal meds. He says, I can irradiate all 5 of them. You took the mic at that time. So what will you do now? You will give RT and the patient's performance status is absolutely okay. So osimertinib, 9 months, RT to the oligoprogressive site. Now after 4 months, first progression, 3 new bony lesions and a new adrenal mets. They said we can totally easily, irradiate all these sites. What would you say?
So first we have done lab biopsy on that.
Yeah,
we can do a NGS. We can do a NGS on that, and we can see the options in the NGS.
Okay.
We can do like that. Or as there is a systemic progression, adrenal mets have come. So we can change the therapy.
Correct.
We can change like we can change to amivantanib plus lazertinib. We can go to that.
Fantastic. Will you want your radiation oncologist to give RT to these 3 new sites and the adrenal is the question that I am asking.
If the patient has bone pains.
No, patient does not have, asymptomatic. He says,
so I think
he says you can continue osimertinib after that 4 more months of AstraZeneca's 4 months.
No, I will not go with that. I will not
Fantastic.
go with that.
I would not like to give RT. I would like to change this.
No medical oncologist wants to give RT, no?
Yes, sir.
Okay,
so
fantastic.
I would like to rebiopsy and change the systemic theory.
So my statement over there to my radiation oncologist actually was, Bhagwan se daro boss, sehne do usko. I mean, that's the typical thing which I said. When they told me they can give radiotherapy, I said, boss, Bhagwan se daro, chhod do. And we didn't allow them to give radiotherapy. Finally, it also helps that the patient was our patient, so we said, okay, fine, don't want to give radiation therapy. But I didn't think, biology of the disease was not really very this thing, and I thought that this is the time to change the systemic therapy. So the MSc discussion was change of systemic therapy. Now, you have already got a biopsy done over here. Bhuva, I start with you only. Now, you have sent a 12 gene coupon panel initially, the coupon one, and now we are also involved in the 4-base care one, which has also got this. So let us say you have done that 4-base care panel and the patient is progressing now. Will you send a NGS once again, and what is your expectation out of it?
I would like to send NGS again, sir.
Okay.
And
what will you tell your liquid biopsy, tissue biopsy, and do you talk to your molecular oncologist before you send this, or you just put the report on the WhatsApp group and say ki baaki log dekh ke bata denge? Amol is there, WhatsApp groups are there now, we have OAG group, something is there now. So, we'll put into that and somebody will come and tell.
I would like to send NGS and with the molecular oncologist, the depth of coverage.
Okay.
Basically, I would like to highlight in my discussion. And the second thing is the web.
The WAF, that is okay, that is there. But anything else in the panel that you would want to talk to the molecular oncologist or something before that? This is what, so this is what I tell my people over there. When you're sending a de novo patient, we write NACLC diagnosis. When you have this, we look at NACLC on osimertinib. Kindly look for fusions also, because fusions are something which which you don't really see. Met amplification or something is what you don't really see over there. We all send osimertinib and this thing. So what has your kuch aata hai? I mean, after osimertinib, we all are very fond of sending NGS for everything. But does something really come into this, or we just send it for the heck of sending that? Your experience of
practical experience, I don't get any.
That's what.
Met amplification and all we expect usually. So I don't find.
Don't really get much out of it is what we are thinking. Your experience, both of you?
I also not seen drastic change or some new mutations or MET amplification after osimertinib. I agree.
So I think it has always been a confusion for me. Whenever you have a EGFR mutated lung cancer, you get progression, you do the NGS, you find the same mutation again.
Correct.
So ye hero hai ke villain hai, you don't know. So
okay.
Most of the times you don't find anything. Sir.
Okay, fantastic. So I will show you the data. I mean, we all are very fond of saying we will send NGS post that, but how much time does it really come? We'll have to see. So this is, I thought some residents will be there. This is my favorite slide actually. When you talk of resistance mechanisms, we always should remember kuch hota hai. Why should we remember kuch hota hai? Because you can have an off-target mutation. That is, you are with a girl and you look towards something else. That is an off-target mutation. The first time somebody took a snap of this was for this only. On-target mutation is you are with your own girl or with your own wife and something happens over there between the two of you, on-target mutation. Or if you change your this thing to something else, that is you change your lineage, phenotypic transformation. So you have an on-target mutation, That is, as Pinaki rightly said, you know, sir, वही mutation दोबारा आ जाती है, or you can get a C797, or you know, you can have a loss of something over there. Off target matlab, you get some new mechanism, you get a MET amplification, HER2 new amplification, ALK disease or something, and if you switch over to small cell lung cancer, that is the phenotypic transformation. This is my favorite slide which I show my residents actually over there. So this is what exactly happens about the resistance mechanisms to first line osimertinib. What I wanted to show you at that time was, please ask for a broad based panel. This 34 gene panel, 50 gene panel is not really going to give you any idea. We don't get anything because we don't look at something. So it's almost like saying we are looking at only this panel. We say radiation वाले तो आते ही नहीं है हमारे उसमें. अरे बाबा जब वो हैं ऊपर वहाँ जाके उसमें तो वो यहाँ कैसे आएंगे? So that is the major issue which happens. Always look for a broad based panel. At our center, what we have done is, when we send for NGS panel, we ask them to do MET amplification separately. Because the molecular pathologists, they don't do MET amplification, and that's very, very difficult to find out the copy gain number and everything in that. Now, this is what we did, Bhuvan at our data. We had around 130 patients who progressed on osimertinib, out of which 80 people underwent biopsy, and this is the 70 people thing. We actually have got MET amplification in 15%. We have actually got 2 patients of BRAF, we have got 2 patients of ALK, and just latest we had 1 patient of HER2 neu 3+, to which we gave Enhertu, and the patient has responded very, very well. So I think it is important to maintain a repository of the data and then look at it, you know, something comes or not. I mean, this is exactly what my feeling was when I gave it to my resident. I told her, yeah, we do NGS for everyone. He said, sir, shut up. You don't do it for 2/3 of the people, because recall bias, that is what exactly happens on that. But this is really there, which actually happened. Ask for a broad based panel NGS, that is very, very important. Now, that brings us to the MET amplification. If you ever go to a Merck symposium, they will say this. Now, how do you basically look for, Pinaki, I'll start with you only. You know, MET amplification is one of the most difficult, complex things which are there. So, anything, Pinaki, you would like to take this? Anybody? No, nobody will. I will only tell over there because I have read about it. So, MET amplification basically can be told in 2 ways. First of all, you have to look at the MET by CEP7 ratio. If this ratio is more than 2.2, then only you call it MET amplified. If it is 1.8, it's almost like a HER2 neu. You know, HER2 neu by CEP7 ratio you say. So if a MET by CEP7 ratio is more than 2.2, or in the trial if the MET copy number gain is more than 10, then only you say the MET is amplified. Less than 5, please don't act on it. 5 to 10, apna dekh lo. If the patient has something over there, then you give, otherwise it's absolutely okay. So what does the NCCN say? A copy number gain of more than 10 or a MET CEP ratio of more than 2.2. That is the say ki if you have got a MET amplification. That's the most important thing, and that is exactly the reason you should talk to your molecular pathologist and ask them to give, you know, something which is there in the, to give the report in the way you want exactly to be. So, Pinaki, I'm not letting you go from this. Now, let's say this patient, you were the one who said, hum NGS karenge. So now MET amplification has come. This patient has come to you, MET amplification is positive on the initial posterior cervical lymph node biopsy. So will you give only tepotinib or capecitabine, or will you give TKIs plus osimertinib? Will you give chemo? Will you give ABCP? Will you give something else?
So now, because we have a MET and a EGFR,
you have a MET and EGFR.
I would go with
amivantamab. One more thing. So even if you don't get EGFR in that, you will presume the EGFR is still the driver. It doesn't just go out from anywhere. So sometimes there is an EGFR loss, but trials have shown that you need to add EGFR osimertinib to this thing. So even if you don't get in that, presume it is still there. Yes. Now
I'll go with amivantamab plus chemotherapy.
Amivantamab, the Mariposa 2 regimen.
Yeah, I will go with Mariposa 2.
Mariposa 2 regimen.
MET TKI plus osimertinib.
MET TKI plus osimertinib. 2:1. Democracy at its full swing.
As there are multiple adrenal lesions, so says the systemic progression. So I will go with amivantamab plus chemotherapy.
3:1. J&J is doing its work very, very nicely. And Merck has work to do.
Mariposa 2.
4:1. We don't even ask you.
Mariposa 2.
Mariposa 2. Fantastic. Which is right. Now this study was basically presented, Sachi study, and Vanita was the discussant for this. This study actually said, so you will talk to the patient. You will tell the patient that, okay, fine, we have got 2 options. One is an oral option, that is osimertinib plus capmatinib or tepotinib, and you have the Mariposa option. Cost wise and everything, actually this option, the oral option, is something which also, because Mariposa is 4.5 lakh rupees per month. OC plus Tepo is actually only around 2.7 per month, and it's an oral tablet. Now this study, the Sachi study, was compared of Savo plus OC versus chemotherapy, and this study actually showed that the PFS that you are going to get is absolutely better than chemotherapy. Now this was not compared to Mariposa, but if I get a MET amplification positive, I would probably give the patients an oral tablet, predominantly because the patient has got oral. And the second thing is, patient will then come and ask me, sir, wo karaya kyun tha? Because Mariposa to you could have given without NGS also. So something came out of NGS, so it is always better to give something in an oral TKI. But I think now tepotinib is DCGI approved for MET amplification in India. Capmatinib is not. So OC plus tepotinib, when you give OC plus tepotinib, two things that you have to basically keep in mind is, always monitor for the QTC interval and the heart. These two things are one thing which are very important. So by and large, what you expect over here is a median PFS of around 6 to 8 months, response rates of around 60 to 62%. Is that what you basically expect? Now let's put a twist in the story. The same patient has now got no axonal mutation. So the patient has there now. Yes.
Just for the previous thing. Is there any data for MET inhibitor plus chemo?
Though there is no data as present of MET inhibitor plus chemo.
Do you think that will come up?
I think the entire thing is
to,
yes, it can be. The toxicity of MET TKI plus chemo will be slightly substantial. And when you can have chemo, so what will happen is you give OC, then you give OC plus Tepo, then you can give Mariposa 2 regimen. You can postpone the chemotherapy to a later time. That's what the best thing is. At present, there is no data of MET plus chemotherapy. The idea is everybody wants to avoid chemotherapy. So now this patient has no actionable mutation. I will just slightly hurry up. How would you proceed now? I think everybody has already said Mariposa is what they really want. Again, if you give only chemotherapy, 4 to 5 months. If you give Mariposa, 7 to 8 months is what you are getting. But if you are getting Mariposa, please be good friends with your dermatologist. The nails will come out. Okay, since this is a non-academic, non-sponsored session, when I speak for J&J, I will tell you about skippers and cocoons. Today, I will only tell you, please be good friends with your with your dermatologist. What we do is we give skin prophylaxis to them from day one. That is the most important thing that is there. Give skin prophylaxis. Once you are done with that, then Mariposa is a fantastic regimen. But the skin toxicity, it's almost like afatinib on steroids. It's almost like afatinib 40 mg being given over there. Can you give only immunotherapy and chemotherapy? No. Even if your PDL1 is 100%, please don't go ahead. Can you give immunotherapy plus Bev plus chemotherapy? Yes. Again, PFS of 2.5-3 months increase, no OS advantage. The only thing to show an OS advantage till now has been not really shown an OS advantage. Trend towards OS is actually Mariposa 2 regimen actually over there. Now, what about the big show, the ADCs?
So I just wanted to ask, have you ever combined amivantanab with osimertinib?
So yes, the AMI and LAZ, the first Mariposa 1 regimen. So lazertinib is almost like osimertinib manufactured in Korea. So what happened was, Astra will not give them osimertinib to combine with amivantamab. So J&J, they purchased lazertinib people, the company producing that. Lazertinib is approved as a first line EGFR TKI in Korea and China. So they could combine, and there was that trial which compared lazertinib versus OC, which said is the same. So that's absolutely okay. The AMI and OC is equal to AMI and LAZ. That's absolutely okay. Next year when J&J launches that, they will give LAZ free along with OC, along with amivantamab. So the big show, that is the ADCs, no talk in medical oncology in lung cancer or breast cancer is now complete with without this. This was the Harthina design. Just because it is the latest one and we tell the patient doesn't mean that it works. Now this was the trial after osimertinib progression. Patients were combined from pemetrexed cisplatin versus the patritumab deruxtecan, and this study basically showed that there was a PFS advantage, but the OS was absolutely like this. I am surprised we didn't hear much about this. You should actually hear Vanita's interpretation of this. This trial, the PFS is coming 5.8 versus 5.4 months. The p-value was significant. Tony Mark presented this in ASCO and he said, there was a statistically significant p-value, 0.4 months, that is 12 days. And Vanita just ripped him apart and said, it was a statistically significant but clinically meaningless advantage of increase in survival. But this Harthena trial basically shows that it doesn't really work the ADCs right now. So even the company has withdrawn the license for patritumab deruxtecan. And to this, I thought this will be Naam Bade and Darshan Chote. I could not get a better clipping than this for this ADCs. But I am a believer that ADCs are here to stay. We just need a biomarker for them. We need to have a biomarker and then things will be okay. Forget about that. So, how much time? 9 minutes. Okay. We do a patient doesn't have money for Mariposa 2. The physician doesn't have conviction for ABCP since it is not a Roche sponsored symposium. He wishes to continue with chemotherapy. Now the most important thing, will you add osimertinib? This is something which most of the WhatsApp groups will ask, people will WhatsApp, ki, sir, now it's a PD. Now do you continue with osimertinib or you say, okay, no, done. We just want to give chemotherapy. We'll start from middle in this side. We'll start from, yes.
Sir, I think we can continue with osimertinib.
We can continue with osimertinib. We'll go this time.
So we'll go with chemo with osimertinib.
Chemo with osimertinib.
Yes, osimertinib plus chemo.
So we have said yes, we'll ask evidence to these guys now. Okay, where is the evidence that you can continue with osimertinib?
Sir,
बोलेगा मैं नहीं करूँगा सर, रहने दो.
Sir,
नहीं तो मैं MSc में आगे इसकी रैगिंग करूँगा वहाँ जाके ना. Okay.
We still presume as a EGFR is a driver mutation, so basically not aware of the data in such case, but I would like to give osimertinib along with the chemotherapy.
We all want to go ahead and it's a TKI dependent thing, so we want to continue this. There is by and large no data actually, but there is a small study which was presented this year by Tejas Patil and Ross Kamach group. Again, what they basically found out, small number of patients, just some 100, 200 patients. One group, they basically gave chemo and osimertinib. Second group was chemotherapy only, and this group is basically when you have not given any immunotherapy. Again, the advantage is minuscule, 2 to 3 months. So we need to understand. So what I tell the patients is, if my intent is, so I was a non-believer in continuing osimertinib because the data had not shown, but you should tell your patient what is your intent. If your intent is to prevent brain mets, or let's say patient has brain mets, and the moment you stop osimertinib, the brain mets will increase, and with some amount of slight increase in PFS, that is absolutely okay. If you think by continuing osimertinib you are going to have a huge 9 months PFS advantage, sorry. So a 2 months PFS or 3 month PFS advantage with a cost which comes with it, maybe if the PAP basically says 6 plus 6 months free and the patient is getting 6 months free, I'll be okay with that. This is the data which shows that yes, you are okay to continue with osimertinib in this, that's absolutely okay. But you should tell the patient that why you are doing what you are doing, and that is the most important thing as far as I am concerned. Let's twist and twirl now. We have put enough twists over here and we have not even come to the oncogene non-addicted addicted this thing. The patient says small cell lung cancer. Now biopsy was done and the patient says small cell lung cancer. So any risk factors at the beginning which will prevent you? I think I will only tell in the interest of time. If a patient has got a triple mutant non-small cell lung cancer, that is a P53, RB1 and EGFR, please always biopsy this patient. 40% of them will turn into a small cell lung cancer. That's the one important thing. Now, we'll start from Pinaki this time. Will you give, everybody will give Utoplatinum. You don't need to be sitting over here for that.
IO plus chemo.
Utoplatinum. You will give Atizo.
I'll give
Atizo or Durva or Tori or Tisli, whatever is now coming up, you will give.
Yeah.
IO and Ito.
IO and Ito Carbo. Fantastic.
Ito Platinum and IO also.
Ito Platinum. Same thing. Gujarati, no? उल्टा करके दिल्ली में आके उल्टा करके बोलोगे हमें यहाँ पे आके.
Sir, Atizo plus chemo.
IO chemo.
Same, IO chemo.
No, wait. Evidence. Defend your friends. Where is the evidence for adding immunotherapy to a Ito Carbo regimen? Yes.
It's an extrapolation from the small cell lung
But
cancer.
extrapolation, so that is what the extrapolation from that is not really the right thing. The transformed cell small cell lung cancer, there is a data for that also. I will show you because we have also given this basically data here shows that there is a very minuscule 2 months advantage in OS also over there. A transformed small cell lung cancer is not similar to a de novo small cell lung cancer. A de novo small cell lung cancer is a totally different phenotype, and a transformed small cell lung cancer is different phenotype. You can give it, but whether it's a standard of care, the advantage is very less actually in this. But yes, there is a study over here which was presented last year, but a very minuscule 1.8 month advantage was basically seen in this study also. You can give it. I'm not a big fan, so I don't push patients for if a patient with de novo small cell lung cancer comes to me, I will actually push for them that 10% of people can be long term survivors. In this, I actually don't push for that. It's okay if you can take it. Most of the times I don't really go ahead and give this. Last, okay, forget it. I think the Dato-DXd, it has been approved right now. We will speak about it when we get the drug. So once the patient has got osimertinib, pemetrexed, carboplatin, and then progresses, then Dato-DXd is there, which can be approved, but nothing really comes over there. So my conclusions on this basically are, not all progressive disease requires changes of treatment. You need to understand about the on-target and the off-target mechanisms. If possible, always do a biopsy to rule out histological transformation. Please look for a broad-based panel NGS. Immunotherapy alone does not really work. Immunotherapy BEV really works over there. Ivonescimab is a bispecific antibody which is really going to come up. Clinical trials are always coming up. We have a clinical trial coming up in which patients in first line progressing on osimertinib are being randomized to SASI-T, that is the MSG this thing, and versus pemetrexed. So their plan B should always be there. Last case, because I have a flight to catch. This patient has basically got a 45-year-old male, never smoker, PET scan lung mass with liver mets, MRI brain normal, biopsy of lung and liver is coem, NGS there was no axonal mutation, BDL1 0, Pembro Paclitaxel Carbo, 3 cycles, partial response to treatment. Obviously we give the same regimen. After 6 cycles, everything was okay, but there was an increase in activity of mediastinal lymph nodes, appearance of 2 new skeletal lesions. MRI brain was normal. So this was what it was, the baseline. This is what first evaluation, and these are the new bony lesions. Pinaki, I'll start with you. So 2 new bony lesions, some lymph nodes over here. What would you do?
Again, if biopsiable, then I'll do a biopsy. If not biopsiable, I will continue the same.
Biopsy, okay, and continue same, yes.
Biopsy and send it for molecular testing again, and depending on the report I will treat.
Fantastic.
Same
So
sir, biopsy. I would like
mediastinal
to.
lymph node biopsy was done, which is negative, but the bone biopsy has not been done, and bone biopsy is pretty suspicious. Sorry. Bones here, the bones is pretty suspicious. Okay, it is not that it is in 2 sides basically.
Then sir, radiation and IO continue, sir.
You will give radiotherapy to the oligoprogressive site, and we will continue with immunotherapy.
So radiotherapy to the oligoprogressive and continue.
Same. We'll do radiotherapy to the bone and then we'll continue with the IO.
Okay, so by and large, again, there is no right answer. There is a data free zone. I'll come to you. Yes, please go ahead.
Same and
Same.
RT2.
So, a lot of times we discuss this patient over there. We can change the systemic therapy. We said we can do biopsy of both the progressive sites, radiation therapy over there. So everything is absolutely beautiful when you stop looking for flaws. Everything is absolutely okay. You can do whatever you want. That's the beauty of medical oncology. We actually asked the patient to do biopsy of both the sides of the mediastinal lymph nodes and also of the bone. Mediastinal lymph node biopsy, he underwent, no evidence of metastasis, only some granulomas. Then we told him biopsy of the bone. He said, shut up, I'm going. He said, then what happened was it took 1 cycle, then the report came next cycle. By the time 2 cycles were already done. So we continued on the same IO regimen. PET scan after 4 cycles actually showed a partial response to treatment. So I think the PET scan reports also have to be taken with a pinch of salt. You have to treat a patient and not really a report. And if you decide to do an investigation, please stick on to it. I mean, that's my this thing, agar ya to biopsy karo mat and write in the file that in view of patient being absolutely okay to continue treatment and do this. But if you do a biopsy and then it comes as disease, then you act on that. You can't have best of both the worlds basically. So I think this was one case. We will stop over there, and ADC is over here, forget it. So just to conclude, progression after first line immunotherapy is very common. Long-term responses and survivors are rare, 20%, but 80% of people will not respond. Pseudo-progression, hyper-progression are rare events, especially in the setting of chemoimmunotherapy or a single agent checkpoint inhibitors. Docetaxel is your go-to therapy in the second line treatment. Ramucirumab, modest activity, but that's what all we have. ADCs, not really yet. Again, we have a clinical trial is going to come up. Every effort should be done to do biopsy and send a broad-based panel NGS to understand the mechanism of resistance. Overall yield may be low. After doing FNACs, biopsies and NGS for probably around, out of 100 people, we have done in 40 people, we have got good results in 2 people. Out of those 2 people, 1 has responded and 1 has not responded. So after you have done a good initial panel NGS, broad-based NDS panel, I'm not very sure how much is it really going to act over there. With this, I always never thought I will come to this, but my heartfelt condolences. I can only imagine what everybody over here went through, everybody had friends at college. It breaks my heart to be even standing over here, but it's just respect, and for everybody, you guys are really courageous for that. Any more questions that you have, I'm really happy to take. Any questions from the house or something? Otherwise, thank you. Okay, we have a question. Yes. We are loud enough? Okay, I am loud enough. I didn't say, I am a moderator. They said. I don't actually. I don't. So let's say it also depends upon, I said, let's say a patient has got progression after 18 months, 19 months, 20 months. It's a small progression. Patient had disease in the brain. I am scared that the patient will really lose out on the brain activity of osimertinib. If then I may combine that with the chemotherapy. But I tell my patients, the reason I am doing is to go only for brain. The activity of this is not more than 2 to 3 months, 4 months of PFS. That's the only thing. I do re-challenge them with TKIs after we gave that initial, so let's say OC, then PEM carbo. I actually re-challenge them with a stronger second generation afatinib or dacomitinib a lot of times, which also gives me a PFS of around 4 months. But as a standard, do I do that? No, I don't. Correct. So in a squamous cell carcinoma, so by and large, as I said, hardly anything you will get. If it's a non-smoker with a squamous, I will definitely do a rebiopsy. See, again, you should understand, when you report an NGS, the VAF sometimes with the report is less than 5%, they don't report. So let's say it was a non-smoker and the EGFR was the low VAF or a tumor heterogeneity was there, then you may get something. But honestly, in a squamous, I can hardly remember getting anything useful. So I'm absolutely okay if you don't do. In a non-smoker person, I will definitely want to do something is there or not. In a smoker which is there, by and large, nothing really comes out of it. Sometimes you get a KRAS mechanism. See, we just now have got a BRAF mutant non-small cell lung cancer. We have done biopsy thrice for that patient. Now she has got a BRAF. With dabrafenib, trametinib we are giving. So, you may get lucky sometime. Will I put my money onto it? No. It also depends upon how much cost will it cost to the patient. In our hospital, we get NGS very, very free, very, very easy and cheap, 20,000 rupees, 25,000 rupees. We can do it when somebody can afford 1 lakh and 2 lakh of therapies. But I tell them the chances of coming anything positive is less than 5%. They still want to do, I do that. Anything from the panelists? Otherwise, thank you. Thank you a lot for having a fantastic discussion. Thank you. Thank you.